you sent me this, and as I said before, like when we when we go over the vent with the students, we have a bunch of waveforms that we look at, and like we don't necessarily know like the backstory. I think that's important because it doesn't really matter the backstory because we should be able to think if we look at the vent, what is happening here? Like what are the possible things that be going on? Sure, there's sometimes that like there's a very specific thing that happened, like I don't know, like somebody cut the ventilator tubing or something. But like outside of that, we should be able to sort of like ascertain like what's happening. So since this is your sort of like slide, I'll can I diagnose it, I guess, and then we'll sort of talk.
I think before you diagnose it, I do just
Yeah.
want to start off for people that are following along, and again, that might be newer on this journey. So let's
hmm
let's ground ourselves first in like what mode of ventilation that we're in, and then where we
hmm
think we're going to look in order to see if our patient might be working too much or too little, or where problems might be. So just to kind of remind people here, if you're looking at the settings, even if you're not familiar with this ventilator interface, you can see that you are setting a pressure and an inspiratory time. So right away, your brain should be thinking pressure control. And then you can also look at your waveforms, and you'll notice your pressure waveform has that nice flat top. So we are achieving and maintaining a pressure throughout inspiration. And our flow waveform is looking very similar to a peak inspiratory flow. So this is looking it's pressure control, but like just kind of for the people following along before Nick jumps in here, that's how we want you to look at this waveform and understand that this is pressure control. And then you need to then think, if I'm going to look at my patient and what their work is, I can't look in pressure because pressure is going to be something that the vent is going to be achieving. So instead, my eyes are going to go down to my flow waveform. No matter what mode of ventilation, your expiratory flow will always be passive and patient driven. So the vent is not active there. But in pressure control, your inspiratory flow is the power. So with that, now over to you, Nick. When you look at
I
this
love that.
waveform, what are you looking at and what do you see?
Yeah, what I see is so when we talk about the vent, at least with the students, it's exactly what you said, which is what's fixed and what's not fixed. So what's fixed is the pressure, and what's not fixed is the flow. So that tells me that the flow is free. So this is like a pressure mode, which could be one of many, right? It could be PRVC, it could be PC, PS. Then depending on what it is, well, like other things will come into play. So if it's PS, then we're going to know that it's a non-spontaneous modes, and things that we're going to control differently are like the cycle decay and all that kind of stuff. So when we tell the ventilator to cycle, this is pressure control. So we're setting the cycle mechanism, which is the instory time. Number one. Number two is so then my eyes go to the flow, as Melanie pointed out. How we teach it is that patients who are passive or paralyzed, the inspiratory and expiratory flow should sort of follow this natural decay flavor, which is based on the resistance and the compliance of the lung. Natural decay and pressure control with the flow sort of looks like this, if you forgive my drawing. So it sort of goes to that, which in depending on the mechanics of the lung and what you set the pressure at, the pressures may or may not equalize. How I drew it, it's saying that at end inspiration, the pressures equalize, essentially that the P airway equals the the P alveolum, or the plateau pressure for just sort of like all the same name. So then you cycle off into expiration, then it should sort of do this in expiration, which is more natural decay, and then come to the baseline. Then that tells us that there's probably no auto peep. That's not what we have, right? What we have is something different. So starting with the in-story side, what we have is the flow is sort of kicked out, right? So what we have is the flow is kicked out this way. So what you're seeing essentially is more flow being delivered to the patient than the patient's lung mechanics would dictate otherwise. This is
Yes.
exactly why, this is exactly why on pressure control, if the patient is active, the plateau pressure can be higher than the set pressure. Because if you add in the work of breathing by the patient pulls more flow and therefore more volume. So my guess would be if we took a plateau pressure on these breaths, the plateau would probably be higher than what we set. And it looks like whoever set this, which is it, did you set this, Melody, or someone else set it?
I don't even remember. This was
No,
in
all right,
my
it was so
phone
long ago.
saved. So it was from
So
ages ago.
and
I
right,
don't think I
so
did. I think I walked up on this one.
yeah, so theoretically the set pressure, which is here, the peak inspiratory pressure should be somewhere like 19 or 18, because the peak is 8, as Melody says, the pressure applied is 10, so then 8 plus 10 is 18. My guess would be if we took a plateau pressure, it'd be higher than 18, because the patient is pulling more flow than their mechanics allow. So if someone asked you, in pressure control, like, or someone says, because I've heard this many times, which is like pressure control, like it's better because like we set the pressure, therefore the plateau can't be higher than what we set. That's only true if the patient is passive or paralyzed. In this situation, you don't know what the plateau pressure is. It could be anything. It could be 30, it could be a million. You don't know what it is because the patient's pulling more flow than the mechanics allow. So,
In
number,
defense of pressure control, I do have to say, as long
yes,
as the patient isn't working, it should be lower. But yes, I agree with you, and I think this is the nuance of ventilation. Like when it gets fun, when you can geek out, is because yes, everything that is a rule, there's like an asterisk beside every single thing because so many things can affect what is truth, even in a mode. Like the
right.
volume isn't always the volume in volume control, and people are
The
like,
volume isn't
"What?"
always the volume. The flow isn't always the flow, and the pressure
Exactly.
for this isn't always the pressure,
Mhm.
which is why when
There's
we think about
always nuance.
when we theoretically, which I think is why it's hard to teach the vent because I think we do it backwards a lot of time. I mean, like we try to when we teach the ventilator, meaning like the course I'm involved with, we harp on what is normal, then we show abnormal. I think in general in practice in like residencies, RTs maybe, um, other like whatever critical care transport, pre-hospital people, we're sort of like going backwards. We're showing abnormal and then just saying like, oh, like trying to do like this sort of pattern recognition, like, oh, this is flow starvation, this is work shifting, this is auto peep, but which is fine, but there's so many things that could be like slightly off that if your eyes can't see normal, that makes abnormal a lot harder to see in certain situations. But so that's what I see. I see patient working, getting more flow. So I'm thinking in my head, I don't know what the plateau pressure is. So am I worried about a 6 cc situation? Because 633 might not be it, number one. Number two is, and we talked about this before, is there some auto peak? There could be, right? Because we don't have the flow come to baseline and inspiration. If I colored in these area under the curve, so the extensori institory limb, would institory be bigger? It might be bigger. So that shows me something else. Number two is we have some delayed trigger here, which can either be the trigger sensitivity too high. I do notice that it was set at 3. That's a little bit higher than normal. Normally we set it like 2. 3 liters makes it a little bit more difficult. It's certainly not a pressure trigger of like 2, which would be like a lot more, but 3 is a little bit more than 2. So, whatever, you take that into account. But a big reason why people have or why patients have delayed trigger is auto peep. So signs of auto peep, certainly. Um, it's a pretty big breath for not that much pressure change. So that essentially means that the compliance is good. Is the compliance good because the patient's pulling so much? So they're applying a lot of they are working a lot. Now remember, when the patient works a lot, you can almost say that falsely makes the compliance better, right? Because you need less pressure change from the ventilator to deliver a volume, which essentially means the compliance is higher, better, but not really better in the sense that like this is a good thing.
I hear what you're saying, and it's true. I usually try to separate spontaneous efforts in my mind, even as a clinician, of like being the other. But like, I get what you're saying.
Yeah. So I think that number one, it isn't natural decay, so the patient is involved for better or for worse. Number two is that there's probably auto peep. Number three, I think there is some degree of work and work shifting. Number one, because there's auto peep, so automatically auto peep is going to make patients work harder when they're spontaneously breathing because they have to overcome their auto peep before the ventilator does anything. So there is that work that we're not seeing on the ventilator that because we don't know how much auto peep there is either, right? We can do an X-ray hole, there could be 15 centimeters of water auto peep. We have no idea. Number one. Number two is um, there's probably auto peep, so the patient's working from that, and you know we would need to probably take care of the auto peep first before we can really think about um, is this the root cause of the work of breathing? So is the work of breathing and sort of this work shifting in air quotes, is it because of the auto peep that's present? And if it is because of the auto peeps that is present, how do we sort of get rid of it? So as we discussed before, the biggest bang for your buck is to lower the respiratory rate. Now you notice the respiratory rate's not really even that high; it's only 22. So that goes back into the original thought, which is, does a patient have emphysema or COPD, where the compliance is so high that for not much pressure change, you get a big volume. As you have a big volume and you don't have, debate like based on the mechanics of the lung, they might not be able to go above a certain breaths per minute, and that could be different for every patient. Which is why I really like calculating the time constant for patients with COPD because that gives me in my mind like a benchmark to shoot for when I'm getting ready to extubate them, right? So if I intubate a patient with COPD and they're paralyzed and I get a time constant, and based on their mechanics, they can't breathe more than like 16 breaths per minute. That's very important to know during the weaning phase, like the pressure support trial, because if they start breathing like in the 20s, they're going to auto peak, like that's for sure. So you need to make a decision at that point, like, do I just take out the tube and maybe put them on BiPAP and let them sort of control more, or am I going to try to fix that to some degree? Like, do I need to give them like steroids, nebulizers, whatever it is? You know what I mean? To fix like the resistance component of it.
So what would you do to fix this? Like I agree with everything you
Oh
said.
man, put me on
Um,
the spot here. So what I would do,
I have a guess in my head. I'll be
yeah,
honest, I don't remember what I did. I don't
that's
remember.
fine.
I don't have an after. This is just a snapshot in time. I have an idea of what I would do, but I want to hear your thoughts.
What I would do is I would probably, so the first thing I would do is I'd probably like play with this percent ramp. It's like 80%. Could you take it to 100%? Meaning instead of sort of that pressure going from 8 to 19 over some time, if you made this 100%, it would sort of shoot up immediately, right? It would be more like that. Now, what that's going to equal is the patient's going to get more volume. Is that a good thing or a bad thing? I'm not sure, right? So the backstory would be very important. Because if we're saying that this patient has ARDS, then a volume of like 700, that would be like probably not great. But if you're saying that the patient has COPD, and they're intubated for whatever reason, and you're not worried about ARDS, you're not worried about the volume as much, there is a ceiling for the volume, right? Like there's certainly a ceiling. And honestly, this patient is probably reaching it, right? Because if this is real and they're actually 73 kgs, like if you gave them any more pressure or time, they'd probably pull a volume close to 700, which is like 10 ml per kg, which that like starts to make me a little nervous, honestly. Um, in the sense that am I starting to cause volume trauma even if they have COPD, right? Like 10 ml per kg, like is sort of my soft ceiling where I start to think, you know, is this getting too high, right? Like, is it too much?
Must be nice to have MD after the name. I'm locked
Huh,
at 8 mils.
yeah, no, I mean, well, like, but for this guy, like eight mLs would be, so that'd be like 70 times five would be, or eight would be, that'd be like 500.
Yeah.
So the thing, if this was emphysema or COPD, I think what my approach is based on this number, which is the minute ventilation, because they probably need a 14 liter minute ventilation to account for their dead space fraction. How am I getting that? Am I going to give them a liter and they're going to breathe 14 breaths per minute? I guess that's a start. Like that's a strategy I can do, but a liter is like pretty big. Like that's a pretty big volume. So anyone looking at that's going to think that I'm completely insane if I do that. So there's sort of like this, like you sort of have to be within the bounds of reason too. Unfortunately, you know what I mean? If I wanted to take immediate control, I would give maybe like some pure sedation and see if I can take care of that autopy and see if that is causing any issues. Like, is that hurting us in any way? Which it probably is, certainly to some degree, because like there is work of breathing from autopeep. But outside of like taking this rate down, um, you're sort of stuck because if the patient needs a 14-liter minute ventilation for some reason, I mean, what can you do? You're already at a total volume of 630, right? At a rate of 22, and there's autopeep. Can you increase the pressure supplied, go from maybe like 10 to like 12 or 10 to 14? You're going to get a bigger breath, right? Because you're setting up a bigger delta. If you set up a bigger delta and you got a bigger breath, now the breath's going to be like 750 or 800 even. I surmise that the rate would come down if I'm correct about that the patient just needs like a 14-liter minute ventilation. So if we did the math and we said the patient needs 14-liter minute ventilation, right? And we gave them a breath of 800, the respiratory rate would be like 17. If like the quick math I did here, my guess would be if they were breathing 17 times a minute, their auto people probably get significantly better. The question is, are you comfortable with a breath that big? That's the
Yeah.
question.
And
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 I don't know.
it's hard to answer. And I think like when it comes specifically to work shifting and some of these, so I like to say support starvation ideas, is a lot of the times it is for patients that are trying to correct some type of acidosis and they are breathing very large volumes. And it is kind of one of those things that the person with that, this is when it isn't nice to be the doctor, because I get to go to you and say, hey doc, so here's the deal. We either allow our patient to do this because I make them comfy when they're breathing bigger, or you decide to take away their power of breathing, and then you have to make that decision. I agree with almost everything you're saying, and I think one thing that you didn't say that I might also offer. Like, I
Yeah,
like the idea of trying a higher flow. I would expect that their peak flow would be blunted a bit if they were or like really spiked, and it's not that high, which is the thing that
yeah,
surprises me. But I do agree with trying that. One thing though that I would probably do is shorten the inspiratory time a bit, because like one thing that I'm seeing, not so much in every single breath, but I'm seeing it in breath one, breath two, and breath three specifically, that it looks like the flow when it finally stops, like starts to turn down, when it drops so powerfully strong like that,
yeah.
it makes me think like we've
It's
chatted
trying to
about this
push out.
before. Yeah, like it
Yeah,
makes me think
no,
that
you're
they're
right.
actually now actively breathing. And then we do have a slight uptick in that pressure that makes me think that maybe there is some cycling or delayed cycling, which I think is
Yeah.
a really cool time to like remind everybody that when it comes to dysynchronies, often extreme work can then cause cycling problems. Often extreme work can like show itself, and you end up having these things bleed into each other that if you're not careful and you fix the wrong thing, you're causing something else. And it's a very dynamic process. But so I would probably do what you said. I would increase the pressure control to try to satisfy that bump up in flow that we're seeing that probably is a patient, but I would shorten my inspiratory time and see
Hmm.
if maybe between that it shortens that inspiration, gives them a little bit longer in exhalation. Maybe that'll help
Right.
with auto peaking. With the ramping, again, also helping maybe shorten that inspiration with that volume and support that we're giving, that again, maybe we can get them to have that more time for them to then slow down.
Yeah, agree 100% with everything you said. And that's, that the waveform I sent you maybe last week or 2 weeks ago. I think it was 2 weeks ago with the patient I have with like severe metabolic acidosis. That's essentially what I did. And I ate the volume. Like he was pulling 750 and he's breathing like 25 times a minute. I mean, his minute ventilation was like close to 20, it was like super high, but he's so acidotic. So even if you said, first of all, you can't get to that with 6 cc's and a normal lung, right? His lungs are normal. Number one. Number two is that's not the problem. The problem is the acidosis. How are you fixing that? So for us, we were sort of temporizing with bicarb drip, then because like there were a couple issues and all this kind of stuff. So we temporized with bicarb, and then we eventually started the patient on renal replacement therapy, right? Like that's the fix. So what we're doing with the ventilator is just like trying to support the patient through that aspect of it. The other thing that I want to say here, because it's like very appropriate, is that for everyone who's like providers like taking care of patients who are going to talk with like renal about starting RT, um, you have to let the nephrologist know, like, hey, yes, we have like sort of a normal pH, like it's 7.25 or something. But if you need a minute ventilation of like 30 to get that, that's not normal, right? Like interpreting gases in the setting of the respiratory compensation is like super important, and it's something that I think we don't think about. Same thing if so happens all the time, right? And you probably see this like multiple times. Patients who are on BiPAP breathing 30 times a minute, pulling a liter or like 700, whatever it is, and they have a 20 liter minute ventilation. Someone gets a gas and says, "Oh, the gas is pretty good. It's like 7.3. The PCO2 is 70, and like the bicarb is whatever." But the patient's like on BiPAP breathing 30 times a minute with a pulling 700. Like that's a lot of work to get that gas. So you can't divorce the gas from like what the patient's doing to achieve said gas. You know what I mean? Which I feel like a lot of people overlook a lot of times. And so I try to like bring it back like, what do we need to achieve that pH? If we need a minute ventilation of 30 to do that, that's not good. That's very bad, as a matter of fact. Anyway, want to do the next one?
Yeah. Oh, look at this beauty. Oh, this one's good.
Go ahead. What do you think?
Okay, so
I also
hey,
don't know the clinical situation, so
so again, like grounding everyone that's kind of looking at waveforms, and this is a new concept. So we are talking work shifting, meaning the patient's doing too much of the work. And this waveform specifically, we are looking at pressure control. We can tell because it's labeled pressure control. How easy is that? But if you didn't have the label, the waveforms actually are going to be a little bit confusing to look at because the patient's working so hard, they have confused the waveforms. But if you're looking at what is set at the bottom of the screen, your eyes might draw to PC above PEEP. So we are setting a
mm,
P meaning pressure, and we are not setting a volume anywhere there. There is a TI, there's a pressure, and PEEP, obviously, with a rate. So we are in a pressure control mode of ventilation. But then that makes it even more interesting because what do we know? What is truth about pressure control? This is one of these fun things with asterisks, right? We have laws in every single mode that we say this is truth, but then there are situations where it is no longer true. And our truth in pressure control is that the vent goes from PEEP up to our peak inspiratory pressure and maintains during inspiration. But here
Mm,
we have a waveform that is not a flat top in pressure control. We have a waveform that is really funky. And so right away, my eyes are like, oh no, this patient is working so hard that they have started to change the controlled variable of my vent. So like this to me is ding ding warning warning warning. And like just coming
mm,
down to flow because flow is normally where we're looking for patient effort. We can again see the same type of thing that we saw in the last one, but that like the waveform is not that nice logarithmic decay that we expect. We are seeing this kick up in the flow, that the flow is moving opposite way, and thinking of the fact that the patient is maintaining high flows all the way through inspiration and still pulling, and we're not seeing this slowing down that we should see with a correcting pressure gradient in pressure control. So with that, the other thing as well is noticing that we don't really have a true like the peak flow itself. Normally we have that nice defined peak with that decay, but we're staying kind
mm.
of really high up in that peak flow, which again is leading me to think that this patient is doing profound work. So and then what else do I see? I see zero flow hold in my inspiratory time, sorry, zero flow hold in my flow time, meaning
Hmm.
that this might be a bit of a cycling issue as well. And looking up into my pressure, I'm seeing a bit of an elevation on the pressure end. So there might be an element of the patient wanting to initiate exhalation earlier. What else do I see? I see auto peeping, which probably also is worsening the patient's work. So our expiratory flow time is not getting back to zero.
Hmm.
Um, and then I don't know if it's delayed. It's a strong trigger. Like I can see in the pressure waveform, we're seeing a massive deflection in the pressure
Hmm.
waveform. It could be just looking at the flow time inspiration or initiation of the breath. It maybe, yeah, it looks like it is delayed, especially at looking in breath 3 and 4. It looks like it's the flow starts to kick up, but then doesn't really drive up. So yes, I would say a delayed trigger as well, probably from auto peep. So a a hot mess in this situation.
But
Um,
the vent's not alarming.
Well, what are your alarms set at there? Let's find your alarms. What did the person set them at? Like 47 million over whatever? Yeah, your minute ventilation alarms are 30 high and 4 low. So yeah, you're not gonna really hit those alarms easily. Peep alarms are quite wide as well, but that's not really one we're looking at. I can't see where's pressure. Peak pressure is 40. But like if
40.
the patient's pulling spontaneously, they're going to create more negative pressure. And our pressures that we're applying are not that bad. So realistically, the tight alarms that we would need here would probably be minute ventilation and tidal volume for pressure
Okay.
control, which I don't see
Okay.
what our volume alarms are. So,
The
of course,
volume alarm, it doesn't, I don't, it doesn't, is there a volume alarm or is it just an MV alarm for pressure control?
it depends on the vent. I would think like,
The vent,
this is a servo, right?
there's a servo.
Yeah, I can't remember for the servo, but usually there is a volume alarm, min and max. Like I know off the top of my head, PB has it, T1 has it, like and Drager has it as well. So I would guess the servo does too. I have worked with the servo, it's just been a while. Um, so I would think
But
so. Like
do you think it's on like a too loose alarm issue or do you think, yeah,
this
answer that
is
question. Do you think it's too loose of a too loose
no,
alarm issue or
this
no?
is not a too loose alarm issue. This is an issue
Right.
of uh, and again, no shade because waveforms are something that took me years to learn. It was not
Uh-huh.
taught to me well in school. But
Right.
this is a person that set up the vent and set up reasonable numbers,
Right.
saw reasonable outputs for peak pressures, tidal volume, nothing too scary, and said, we're good without
Hmm.
looking at the waveforms and seeing what it truly is telling them. And I think sidebar, but I have to say it. This is why every single clinician who works with events needs to know waveforms because the numbers might look pretty. And if you
Mm.
don't have an understanding on waveforms, you might think that you're doing okay for your patient. But this is a situation where the pressures aren't terrible. They're not breaking any rules of
Right.
plateau. Well, actually, your plateau probably is higher here, but that's a sidebar.
What's
But like
what's the plateau is a real question, right? Like we don't
it's gonna
know.
be
We don't know what the
it's gonna
plateau
be
is.
higher. Yeah.
I thought pressure control, it's we set the PEEP at 5, then the PC above PEEP is 15. It should be higher than 20, right?
Yes,
Was
and
26?
I think here that this is telling you that like without truly digging and like understanding the nuances of all of the problems with a patient actively working or like with modes of ventilation, you can end up having numbers that might look on the surface as great, but
Hmm.
then when you look at the waveforms, you can see profoundly that this patient is uncomfortable and that things are unsafe for this patient.
So what would you do? What would be the first fix that you would try?
Okay, so most likely, let's see. One thing I just have to figure out here. So spontaneous. So they're all patient-initiated efforts. So
Hmm.
I can't slow them down for that. So that I think the first thing that I would do is I would try to match their intrinsic effort. Like
Okay.
usually in a situation like this with profound work shifting, I do try to go to pressure support and support them with like a reasonable pressure support at around like probably here I would give them pressure support of 15 and try to see what they're doing for their drive.
Okay.
But if
Okay.
I did not do that and they stayed in the mode, I would
Yeah.
probably try to match their inspiratory time with that, trying to support them there. What's the T rise? 0.2. We could try to increase that and see if that gives me a bit more flow on the
Hmm.
inspiration of the breath. Because
Hmm.
remembering that low flow varies, it is also limited by the amount of pressure you can apply within the circuit. So if we're telling the vent you can apply more pressure, then it's going to mean more flow. Um,
Right.
so if shortening that rise time in order to achieve that pressure quicker, and then for this patient with that scoop that I'm seeing in the flow waveform, they need more support. So I would probably up my pressure control, try to settle them, and then see if with supporting their work, if they start to slow down, and then I can start to peel the onion that this patient probably is to figure out how to get them comfy. Because like at this point, it's chicken or the egg. Are they pulling so hard because they are, just so support starved, or are they auto keeping it uncomfortable and that's making them pull harder, that's then worsening the work and it's becoming this
Right.
vicious cycle? So I feel like in this case, you almost have to hit it from multiple angles. Try to fix the auto peep the way you can by shortening your inspiratory time. Give them a bit
Hmm.
more support to satisfy that shortness of breath that they're feeling. Get rid of the dyspnea, and then from there, see if we can get them to settle. And then at the same time, maybe asking the nurse if there's a PRN sedative I can give them just again to try to calm them a bit, so I can try to get them more comfortable. What do you
So
think?
you, no, I think that's fine. I think that, I think a lot of people that I've seen at least recently would say something to the extent of like switch to pressure support to see what they're doing type deal. I think the thing to highlight though is that's giving the patient the most freedom on the vent is pressure support, right? Like controlling the rate, controlling their eye time, and the volume to some degree, like depending on the pressure you set. Like that's giving the patient the most freedom, which is a double-edged sword. Like if you don't want this patient to have the most freedom, then you need to think about that. But if you do, and you want to just sort of like see what their sort of like neural breathing pattern is producing, like PS is the best way to do that. So I agree with you. I would switch to pressure support and see like what their mind wants. Like that's almost how I think about it. Like I can't, I can't ask the patient like, do you want more pressure? Like whatever, but I can switch them to pressure support and then see what the waveform gives me. I
Yeah,
think, and just to
I
sort
want
of
to
like bag.
argue. I want to argue with you
Okay,
here
all right, yeah, argue. Go
because,
ahead.
and it's not, you're not wrong, but I also think like essentially pressure control and pressure support. If I flip this patient
Yeah,
into pressure support of 15 above PEEP of 5,
right.
and with this patient who is currently triggering every single breath, hey, Nick,
Hmm.
what's the only difference between pressure control and pressure support?
The the cycle.
Yes. And so though I agree that you're giving more responsibility to the patient, right now the patient has all the responsibility. And I think all I'm doing there is I'm eliminating one more variable that the vent is putting on the patient that it might be confusing the
Yeah,
waveforms. And that's my logic of it. It's not so much that I want to see what the patient's doing so much as I'm trying to eliminate the dumb ventilator that's screwing up something. And if I can eliminate that and then see the patient working underneath, then me as a clinician can say, okay, ventilator, like I'm going to fix this now. And then now that we know what the patient wants and I'm seeing their own cycling, I'm going to go
yeah.
back to a control mode and match
Oh,
that.
I gotta be honest with you. I feel like we said the same thing in a way, but you're argumentative, which I love.
Well, I think it was the way
No,
you
no,
said,
no.
the way
You're
you,
like you're right. Like that's exactly what I mean. And so I'm going to use that opportunity to bag on PRVC because that's exactly what PRVC doesn't allow you to do.
yes.
Is like it just applies its dumb algorithm to a patient that's like floundering, and like you said, you take away the dumb ventilator and like see what the patient's doing. Then from that, it's like, all right, so they're breathing like whatever, like I don't know, like 20. So this is 28. They're breathing. They probably want to go faster, right? Like because of your delayed cycle, like they want to go faster, or they want more breath, or they want like a bigger volume or something, right? So either you're going to set like a higher pressure, like inspiratory pressure support, for some time, or you're going to decrease the time. They're going to breathe faster. Now you're going to have to negotiate the auto pee with that. But I think the thing that we're both highlighting is that like you're just taking the vent out of the patient's way and letting
Yeah.
the patient do what they want, and then sort of like backfitting the ventilator settings. If I mean, I
Yes.
don't know, do you leave them on pressure support like in this situation? Would you just leave it, or would you sort of like not, like take the vent out of their way, see what they're doing, and then try to like retrofit the vent to their to what they want, or you
That's an
just leave it?
excellent. I like that. And I think if it was in a vacuum, this patient right here in front of me that I'm looking at right now that is initiating every single breath and is showing that they're uncomfortable on the control mode in a
Yeah,
vacuum with no other clinicians, no other anything, I would leave
yeah.
them in support. But then there's the
Okay.
variable of the what infusions are they on?
Yeah,
Are they
right,
going to get more meds? Are they going to
right.
start to like, and they are too acute, obviously, because of how they're breathing to probably stay in pressure support because inevitably they're going to end up with more sedation on board. Let's be honest. Or another clinician at the bedside might end up trying to play with the inspiratory time or like not necessarily. I kind of got lost. But if I leave them in pressure support, I feel like
Yeah,
they might end
like
up in something worse off, like PRVC. Or so
good point.
for me, I probably would try to then go back to pressure control and match them and leave them in a control mode because I think the risk of leaving them in pressure support with maybe someone following that then decides or giving more sedation or something,
Yeah,
I I, I tend to like to leave them back in a control mode.
yeah. No, I do too. I agree 100%. I usually put them back into controlled mode, because not like I don't know. There's a lot more nuance you have to be aware of if they're in pressure support. And I don't know about you, but for some reason, there's like this very like oh my God, this like very ingrained um thought that the patient's in pressure support that like, oh, are we like extubating? I'm like, no, they're just in pressure support. Like they're, like
Yeah.
they can breathe at their own pace and like control more. And no one can seem to really grasp that, like, oh, like the patient could be in pressure support, like as a mode, like it doesn't have to be PC or PRVC or whatever. Um, so just I find that when I leave patients in pressure support, there's like all these questions from like RT, the nurses, the residents, like, oh, like they're in pressure support. Like, are you extubating them? Like, I thought they were really sick, da da da. And I'm like, no, they're just in pressure support because we want to give the patient more freedom. But no one can seem to grasp that like pressure support is not just like we're going to pop them on pressure support and then pull out the tube later. Do you know what I mean? Like, I don't know. Do you get that? Like, do you also get that sense in the hospital or not really?
I have to say no. Like I have to give huge props to my coworkers and um and I don't even it's not, I don't even know, but like the artists I work with
Yeah.
are very much of a similar mindset that like spontaneous and is a mode to use in many situations and we
Hmm.
strongly advise, and I know myself when I'm teaching in my main role that I advocate for pressure support as the initial mode as soon as possible in many
Yeah.
situations. And like um it, so I don't find I come across that too much, and I don't know if it's just different cultures of different areas and regionality to it. But
Yeah.
I find in the multiple places that I practice, pressure support is very well established as it's not just a weaning mode, and it's not just what you put the patient in later on. That it's often that I will have a patient that is on higher levels of levofed that is not even eligible for an SBT according to our little guidelines and protocols, but they're in pressure support. We're just not
Right.
necessarily doing SBT. So
Oh, that, yeah. No, unfortunately, I don't get that sort of, it gets much more convoluted. Like, for example, if, a patient's in pressure support trial, 5 or 5 or something, and they're failing, because they're tachypnic or the volumes are low, and I just walk the pressure up to like let's say 12, and the volumes are better. I just tell them I'm like just leave them at 12. Just leave at 12. Like just leave them on 12 or 5. And if the patient's on that for more than like an hour or two, there's like so many questions like, are we going back to pressure control or are we going back to PRVC or whatever? And I'm like, well, is the patient worse or something? And they're like, no, no, but like we're not extubating, so why are they on pressure support? Like can't seem to grasp that pressure support is a fine mode to be on as long as the patient's spontaneously breathing and you're not going to provide some medication or whatever to prevent them from breathing, right? So if you took the patient off propofol or whatever, Dex or something, to do the trial, and then they get, so they get a little like a little rowdy, and you think they need sedation back on, um, then that's one situation that where you might want to go back on a controlled mode just to sort of be a bit more safe. But otherwise, like I like to leave patient on pressure support, right? Like, I mean,
yeah. I think what you're
especially
saying right here is like one of the best ways that we could even like leave people with when it comes to a lot of like pretty much ventilator dysynchrony in general is that half the time we screw it up with our settings of like
Yeah.
of textbooks telling us we need an I to E of whatever or an inspiratory time of whatever
Oh
or
God, not the
respiratory.
IDE,
I
please.
know,
Give me
but
PTSD.
seriously, like or a respiratory rate of X or Y or a minute ventilation of what. So we plug numbers into the ventilator and throw it up there with us, and we have a specific trigger and a specific control and a specific cycle, and it's cycling down to whatever baseline. But then we have a patient on the other end, and that patient on the other end, if they are not sedated fully and they are not paralyzed, they have their own neurologic drive to breathe, and that is
Right.
happening and it is occurring. And as they become more sick, that worsens. And reminding people that when it comes to modes of ventilation, if you don't have all the fancy tools and the esophageal probes and NAVA or and PAV, that pressure support is going to be the mode of ventilation where the least number of variables is controlled by the settings, and the patient has a
Right.
bit more power, even if it means it is just cycling. That is a bit more power, and that in itself can sometimes get you out of your own way when it comes to these dysynchronies and figure out how to match your patient if you can't just leave them in pressure support.
What mode do you think gives the patient the least amount of freedom?
Ooh. Ooh. Um, um, Probably PRVC. Like to be honest, out of the control modes, because it's hard to say because the four variables that we talked about at the very beginning, like pressure or volume or flow or time between pressure
Hmm.
control and volume control, I feel like essentially there are equivalencies between those two different options. PRVC, I feel like trying to do things ends up worsening the situation, and the
Right.
patient doesn't have control on volume or pressure because the vent is
Uh-oh.
dry. So I feel like PRVC is a lot less.
Yeah. No, that's fine. I knew you were going to say that, and I set you up to say it, and it was perfect because, and I agree. I very much agree, obviously, that it gives the patient the least amount of freedom. Maybe not from just like the four settings standpoint, because in reality, you do set a volume and like whatever. The problem is, as the patient participates more and more, the ventilator changes more and more. So it's
Yeah.
not from like a setting standpoint. It's from like, as you said before, it's like the patient is like sort of a constantly moving target, and then the vent's also a constantly moving target. So you're sort of trying to balance two things that are doing their own thing to work to try to have them work in unison. But like as the patient does more, the ventilator then does more to try to compensate for what it thinks it should do. So in my mind, as I've said, like, oh my God, ad nauseum by now, is that I think it's the worst mode because you're giving the ventilator the freedom to do what it thinks it should do. And most of the time, um, when you need it to do the least, meaning like get out of the way the most, it's when the patient's like the sickest, and then it just does whatever it wants, and then things just like get off the rails. So I
It's the
agree.
second, it's
I
the
think it's
second
PRVC.
worst mode. It's the second worst mode.
What's the word? Simvi. Jesus Christ. Oh my God. I knew it was gonna be
I
that.
will die
Oh
on
my
this
God.
hill. I will die on this hill.
No, I mean no Simvi. Jesus. Yeah. No. It's. I mean the problem like I guess we'll just end here. Simvi is the worst. I think Simvi was created with a good intention. I just think that
Yeah,
its
it
its
wasn't.
execution, like its execution wasn't great and its use wasn't great either. And the fact that like we don't wean people anymore, right? Like we're not weaning per se. We're just assessing for extubation readiness. So I just don't see a role for Simvi at all. I mean, it just doesn't, right? Like if you're using Simvi, just use PS, really.
Yes,
You know what I mean? Because the patient's going to be breathing on their own. So just like use pressure support and be done with it. Like why
exactly.
switch between two? I just don't
Yep.
see a role. I just don't see a role for it, I think, is really what it comes down to.
Yeah,
So
exactly. No, I think that sums it up well. I think like pressure support is a great option. I think it solves a lot of problems. And like when you are in the weeds with a bad waveform that you don't know how to navigate, the one of the best things you can do is eliminate variables by seeing what your patient's doing as best you can
right,
and like put them on pressure support, put them on higher pressure support than you might think. So like when I say that, I'm not saying like 22, but I'm saying like give them a pressure support that's supporting their work of breathing. So give them pressure support of like around 15, 12 to 15, somewhere in that range. See what they are doing, and then you can work backwards. And that like when you're lost, that's a good place to start. And sometimes that's a good place to end until you can get them where they need to go. And sometimes pressure support is a great option to end at, and it just
agree,
depends on the situation.
agree. But I agree wholeheartedly. But you are giving the patient freedom, and that's not a bad thing. But you just need like that needs to be in the back of your mind. It needs to be in the back of everyone's mind. The nurse, the RT, the physician, like whatever team is taking care of the patient. That like, hey, Mr. Jones is on pressure support because like we had him on pressure control or like VC or whatever, and he just like doesn't look good on anything, so we left him on press support. He looks the best on that, but just be aware that that way, if because and that certainly to the point earlier, that's probably where you want your alarms much tighter, right? Like you want them probably tighter, so the vent might be dinging more, which gets everyone in a tizzy. But like it's important to have the vent like let you know, like, hey, there's an issue, you should look at it. So it, it's not a set it and forget it thing. You really need to be like cognizant of what's happening, like when you leave someone on pressure support. But sometimes it's better, and it's better for the patient, and they don't feel like they're sort of like struggling the whole time. So I agree with you. Okay.
Well, with that, shall we end it for now?